Welcome to today's presentation on prolonged exposure and somatic therapy utilizing ESFT to treat childhood and child sexual abuse. My name is Dan Gilmore, and I'll be presenting today's presentation. What we want to learn from today by the time we are done is the ability to synthesize ESFT with prolonged exposure and somatic therapies to address child sexual abuse in parents. We also want to be able to demonstrate the integration of ESFT, prolonged exposure, and somatic therapy through a case study. And we want to evaluate the integrated model and discern key challenges to implementing. Although there is no universal definition of trauma, this definition from SAMHSA in 2014 embraces core components to traumatic experiences that someone might have. It says that it's an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and well-being physically, socially, emotionally, and relationally. I think I like to highlight that trauma, by this definition, has lasting adverse effects, and we'll talk more about those effects, and that if an individual's functioning can also be impaired, and that's in these five different areas. Some people would also add spiritual well-being as a negative impact of trauma as well. So when we talk about child trauma, we know that there are lasting impacts. One of the ways that we know that is the research through maternal trauma. Maternal trauma is parents or adults who have trauma, in particular mothers in this case. They've done research to see what was the effects of that childhood trauma on their parenting abilities and how it might transmit or translate the trauma to their own child. Robinson et al. Says that parenting is a primary route for children to develop socially, emotionally, and that parent trauma can impact this transmission. Maternal depression is linked to childhood trauma. Physical abuse in childhood was also related to the increased anxiety in children. Another study by Choi and Kangas showed that maternal trauma, especially betrayal trauma, was related to lower parent and child well-being. So we know that when a parent has had childhood trauma, that those effects of that trauma can be long-lasting without treatment. And what it's saying is that it impacts the next generation of the children who are being parented by the mother. So let's talk about what is child sexual abuse, because in particular today we want to look at child sexual abuse and parenting. Again, there's a lack of universal definition and criteria. Unfortunately, that seems to happen when we talk about some of these specific abuses. Child sexual abuse is different than unwanted sexual experience, and how do you look at that? And then another reason that there's a lack of definition is because there's just various fields that are interested in child sexual abuse. So public health law is going to be different than public policy, might be different than social science, might be different than the Department of Human Services. The World Health Organization put out a definition in 2003, and even though it's been quite a while, it's actually a very good definition of what child sexual abuse is. And it says that child sexual abuse is any form or all forms of physical or emotional ill treatment, sexual abuse, neglect, or negligence of treatment or commercial or other exploitation resulting in actual or potential harm to the child's health, survival, development, or dignity in the context of a relationship of responsibility, trust, or power. The rates of child sexual abuse in the United States is about 1 in 4 girls will experience childhood sexual abuse in their lifetime, and 1 in 13 males. And that's from the Center for Disease Control and Prevention from 2020. The numbers may be inaccurate, especially when we look at the studies with males. Oftentimes, because of the shame that goes along with sexual abuse, males are less likely to report sexual abuse. And even with girls, because of the nature of the abuse, it often goes underreported. But these are rough numbers, gives you a good idea that there are a large percentage of adults then who have had child sexual abuse as part of their history. I mentioned betrayal trauma when we talk about maternal trauma, and I want to highlight that here because betrayal trauma is a little bit different than what we consider other traumas. And the reason is it suggests that the closer interpersonally that the abuser is to the child, the higher rate of the trauma, meaning when you have a father or an uncle or a mother or a sibling sexually abuse you or abuse you in any way, the chances of there being symptomology is higher in what they call betrayal trauma. We know that Babcock Fernici in 2016, they said that betrayal trauma predicts greater internalizing and externalizing behaviors in school-age children. So the adverse effect of that betrayal trauma ends up in the behavior of the children that are being parented by these individuals who have betrayal trauma. And it's important to understand too that how parents communicate to their children directly impacts their social and emotional development. So we know that those who have had betrayal trauma and are parents, similar to maternal trauma, have harsher ways of dealing with behaviors of their own children. And so because of that, we know that it's going to impact them socially and emotionally, and that can be a challenge. I want to also highlight polyvagal theory here, and it's how it might relate to parenting. This is a brief overview of the polyvagal theory from Porges and Dana, 2018. But the polyvagal theory is basically an explanation of what happens when trauma occurs and how does the body respond, in particular the autonomic nervous system, the parasympathetic and the sympathetic. And Porges proposes that there are three different responses that can occur when the environment around them impacts the nervous system. And when we're talking about trauma, we look at it from this perspective that when a trauma, like childhood sexual trauma, occurs outside and inside the body, the nervous system responds. In a case of sexual abuse, it is definitely perceived as danger or life-threatening. And so when danger occurs, typically our autonomic nervous system responds with the parasympathetic nervous system and the sympathetic nervous system. The sympathetic nervous system goes on hyperarousal, mobilizes our fight and flight, and allows us to do what we need to do to be safe, right? Hypoarousal, if we feel like our life is threatened or we're in danger, hypoarousal can be when our parasympathetic nervous system gets engaged. In particular, Porges talks about the dorsal vagal system. And when the dorsal vagal system is activated, that causes problems with how one relates to others in particular. So when an adult has childhood trauma, childhood sexual trauma or abuse, and they are in this hyperarousal state, whether they've been triggered by their environment, by their child, oftentimes it's their children or other life stressors, their dorsal vagal system kicks in and they are in this kind of dissociated collapse where they don't have a lot of emotional expression. So their muscles in their face kind of get hardened. It's harder for them to smile. Even their gaze is different, and it affects the vocal cords. And really what is happening is the ability to engage others goes down. And what Porges says our body should be doing is determining when we're triggered by trauma in particular, that we are actually safe, that this is a past event, And then when that happens, when we are understanding that and our body responds that way, it activates the parasympathetic ventral vagal system. And the ventral vagal system is what they termed the social engagement system. And the reason is because when the parasympathetic ventral vagal system is activated, that is when we have good eye contact, and good eye contact relates to attunement and attachment. We have facial expressions. We're able to make big smiles and laughs, and we're able to invite people with our smile and our eyes. And then our vocalization, even our vocal tone is lighter and happier and more inviting than when we are in either hypo or hyper arousal. And so the reason I bring this up is because parents who have child sexual abuse may find themselves constantly being hyper aroused or hypo aroused. And in hyper arousal, it's easy to recognize. Typically, we know that that's the angry parent who's yelling and screaming. When we talk about maternal trauma, the ones who are like more physically aggressive with their children. Hypoarousal is a little harder to recognize because those are the ones that just seem disconnected and not there. And that is hard to attach to. And we're going to talk about why that's a problem later. But I introduce Porges's ideas because I think it's important to think about when we think about parents who are have experienced childhood sexual trauma and how they might present to their children. Some of the early studies around the effect between trauma and the body have to do with the ACEs study. Now, others were looking into the connection between body and mind and trauma, but Folletti et al. In 1998 put out the comprehensive ACEs study. And the ACEs study really changed how people viewed the impact of trauma. Now, the study said that adverse child experiences like parents who have mental illness or parents who have drug abuse issues or actual abuse or childhood sexual abuse, those children end up growing up having social impairment and emotional impairment. They have health risk behaviors. They're more likely to have disease or social problems and more likely to die earlier. In fact, the top 10 at the time adult causes for death were related to the adverse childhood experience, meaning the higher the adverse childhood experience score, so the ACEs score was, the more likely it was that they're going to have these issues. So again, this is proposing that children who have child sexual abuse become adults, and when they become adults, if there's not been resiliency or trauma therapy or healing, then the parent may continue to present with some of these deficits. And we'll talk about some more of them too. But an interesting study by Byers et al. In 2022 connected high parental ACE scores with ESFT, which is ecosystemic structural family therapy, and the effectiveness despite those high ACE scores. And we'll get to that a little bit more. But the ACE scores is one of the premier studies that links the body and the effect of trauma in childhood to adulthood. An interesting sidebar to the ACEs study is the idea of how does trauma and social location impact the ACE scores. And so this came about, there was a lady also at Permanente in San Diego, I believe, who was working with adolescents, and she was doing ACE scores, and even children who reported no trauma, specific traumas like abuse or events that had occurred to them, were still scoring high with the ACE score and still had high symptoms. And so they began to look at it from a different perspective. And that perspective was that even things like racism, genderism, poverty, access to care, those things can also impact an individual the same way that other traumas do. And we know like generational traumas and historical traumas as well impact the person's mind and body in the same way that um, a parent who is uses drug and alcohol, or a parent who is abusive. And so this little chart just reminds us that children who have grown up in settings where um, they may not have had a specific trauma, but where they had lack of access to care, physical health care, mental health care, or lack of access to housing or food, may also experience some symptoms of trauma as well. So I want to move towards the beginning of our integration of these models. And first, I just want to introduce ecosystemic structural family therapy. If you're not familiar with it, it is a trauma-informed systemic treatment designed to serve children with serious emotional disturbances. Let me just add a little bit to that. Serious emotional disturbance is equivalent to serious mental illness in adults. SED means that a child has mental health challenges that are heightened by serious diagnoses such as either DMDD, bipolar disorder, ADHD is on there as well, major depressive disorder, and some others. But ESFT was designed to serve those types of children and their families. And when we talk about ESFT, we're talking about a treatment that works with the child and the caregiver to address four areas, and they're known as the four pillars. And those four pillars are emotional regulation, attachment or attunement, executive parenting skills, and support for caregiving. And so when someone is in ESFT treatment, these are the four areas that they will be focused on. In fact, some of the treatment plans from agencies that use this model have specific goals for each of the four pillars. And really, emotional regulation is helping the child find a way to regulate so that they are not as explosive or not as risky in their behaviors, so that they can avoid suicidal ideation and not so much ideation, but suicidal behaviors. And so that they can interact differently with their family. Although the pillar is mostly focused on the child, it also involves the parent. And a lot of the parents that come into ESFT have childhood trauma. They have child sexual abuse trauma. And because of that, they also have challenges with emotional regulation. Attachment and attunement is how does the parent see the child emotionally? How much do they know about the child emotionally and psychologically? How much do they understand that child? How do they see the child? Do they enjoy being with the child? Do they spend time with the child? And we're going to talk about how that might get impacted by trauma. Executive parent skills are really, these are skills that parents have that help run the household. So a lot of families have different ways of being, but in every family, there should be some sense of order, structure, routine, because those are going to help the child. And so some parents are really good at that, and they're really good at setting up structure and routine and expectations. And some parents really struggle. Parents who have trauma are going to struggle because of how trauma affects the executive functioning of a parent, meaning the planning, strategic, strategizing part of our brain goes offline when trauma is triggered. And so those executive skills that a parent might have may fall to the wayside when they're triggered by trauma. And finally, we're talking about support for caregiving in ESFT. And support for caregiving really is building a community around the parents and with the child so that caregiving can be easier. The old adage that it takes a village to raise a child is really kind of this idea here is that if parents have people to go to talk to pull in when they have challenges, then they're more likely to continue to be able to parent well. I'm just going to name four very quick strategies of intervention in ESFT. And these come from the structural framework of the model. And it's really big on joining. So the clinician and therapists work really hard to create a space that is safe for everyone, for the child, for the parent. And that happens through this process of joining. And that process of joining is really just connecting with the family in a way that they invite you into their system, meaning they see you as part of what's happening and that you have influence over changing that system. Boundary making is a quick tool that can be used in sessions where you make sure that the right two people are talking. Oftentimes, when parent and child are in conflict, if you have a parent who has trauma, they may get dysregulated and they may pull in a child or another child to help them, face this other child. So creating triangulations and, boundary making by the therapist is just to, hold on, mom, you need to be talking to your child. This is between you and your child. You need to leave the other child, the older child, out of it in this moment. So that's a boundary making. Reframing is done through looking at this from a systemic familial lens instead of a behavioral lens, meaning the child is going to have behaviors not because they are bad kids, but because they have challenges and they have maybe lack of skills. And this is more about skill than will. Same thing with parents, reframing that parents are doing the best that they can do with the ability they have, and that some parents are struggling not because they don't want to be good parents, but because potentially they have never addressed their trauma, or they have other issues that are impacting treatment and the ability to parent. And then enactments is a structural term used to create a conversations between two people or interactions between two people, typically between parent and child. And this is where we will talk about creating opportunities to use some of the strategies from somatic therapies and how to help address the child sexual trauma and the triggers to that through these enactments. Outcomes for ESFT, it is an evidence-informed practice. It doesn't have enough randomized controlled trials. In fact, it doesn't have any, but it does have quite a few different research studies that have been put out there. The first one was published in 1998, and that was the largest of the studies. And it said that the ESFT does what it's supposed to do. It reduces out-of-home placement, allowing children to stay in their home instead of being placed in residential settings or in inpatient hospitalizations. Other studies, Herschel et al., Jones et al., Byers et al., have all shown that ESFT helps reduce out-of-home placements in children with serious emotional disturbances. And like I mentioned before, Byers et al. Had a study in 2022 that showed that even if the caregivers have high ACE scores, ESFT can be effective in the goal of reducing out-of-home placements, which means that the treatment helps parents who have these high ACE scores, right? So let's look a little deeper at how does ESFT address trauma? And it really is based in the trauma-informed model of ESFT, which is that trauma is something that we have to be aware of. Many of the families that ESFT addresses have parents who have their own trauma or kids who have trauma. And so, it's something that is occurring to the family or to the individual, and it's going to impact the child in all those areas we talked about before: mentally, physically, emotionally, socially, spiritually. And the same thing with parents. So ESFT looks to acknowledge trauma, and to address trauma, and to look at it from different lenses. Now, it's not a trauma specific treatment, but the four pillars really do set up an opportunity for it to address the trauma of both parent and the child. So let's look at the attachment pillar. So the attachment pillar focuses on attunement to the child's emotional experiences and relationships. And this is the place where the polyvagal theory comes in. When we want to address a trauma, when we want to address attachment with a parent who has child sexual abuses, we may find, like I said before, that they are in the dissociated phase. If you have a child who is looking at their parent for emotional response and regulation, and the parent is a blank slate, that's very disconcerting to a child. They don't know what to do with that. It makes them anxious and nervous because there's no emotions coming out of the parent. And so a parent who has child sexual abuse in their history may be in this dissociated phase and may be struggling to know how to attune and attend to the child because they're just not there. They're really dissociated from it. And in ESFT, what we would do, we would look at that and one, identify that as, okay, this parent has childhood sexual trauma. We're going to talk about how that would work. And then we might use some of the skills from polyvagal theory, somatic theory, to help engage the parent more emotionally, so that they can better understand what's going on for their child. And we would use enactments to do so. And so this attachment pillar really is a trauma pillar in the sense that we're helping parents be more attuned and attached to their child, which is going to help them and their child with any trauma symptoms. And I'm just going to say this here, the attachment piece really comes from John Bowlby and Mary Ainsworth and all their work. Jones and Lindbergh, Goldberg address the attachment piece as a unique part of ESFT. And really, they lean heavily on John Bowlby's work about what attachment is, that it's an lasting emotional bond that one person has with another, and it begins to form very early in infancy. Another piece to that would be, if you think about the parent, then if they're abused sexually as a child by someone that they love or care for, then it's going to be really difficult for them to really form an attachment that's an appropriate attachment, right? It's going to be a maladaptive, insecure attachment with this person because they are abusing and they're sexually the child. And so we also think about it from that perspective. So when you think about working with the parent and child, oftentimes it's not just the child that's struggling with attachment or the parent, it's both. They both come together and have challenges because of their own histories. And sometimes with child sexual abuse, the parents have a harder time because of that. Emotional regulation pillar is another pillar in which ESFT uses to address trauma. And we know from Lukenmeyer et al. That parent regulation is related to the child's emotional regulation. So if you want to address a child who is disruptive, dysregulated, maybe challenging with these serious emotional disturbances, then a parent has to be regulated to help that child. And co-regulation only occurs if the parent can be regulated. And so again, in this emotional regulation pillar, the therapist would be looking to implement some somatic therapy strategies with the parent and child to learn how to regulate their emotions and then how to do so together, right? How can the parent and child co-regulate when they need to? When we talk about regulation and attachment, I want to bring up two other pieces, and that is Ed Tronick's work with mutual regulation. Ed Tronick is a professor at Harvard. He took attachment theory, wanted to know the mechanisms between caregiver and child. If you're familiar with the still face experiment, that's who did that study. And really, what he did was he broke down the moments of bonding in children and parents. And so, one of the things you see in that is that when a parent is emotionally responsive to the child and available, children are very comfortable. Right? Look at the picture to the left. You can see that when the dad is in the child's face, laughing, smiling, having fun, the child is responsive in the same way. Um, in trauma, and he says that this happens in everybody, but at any moment, that mutual enjoyment and a bond can be broken. And it can be as simple as the parent gets a phone call and turns away from the child, and that distresses the child. Um, the parent will then hang up the phone, turn back to the child, and things are fine. But he says that each of these little moments where there's a break, um, that's when bonding actually is created, because it's created between the parent and the child when the parent comes back to the child, when they repair that little break. Now, child sexual abuse is a big break, right? If a parent has child sexual abuse, um, they may have not ever seen a repair in their attachment with their or bonding with their parent. And because of that, they don't know how to reconnect or repair relationships. And so Ed Tronick did a lot of work with this. He put together a mutual regulation model, which basically works with parents and children to process all these little mini breaks in vivo. And so one of the examples he used was putting a parent and child together to do an activity, whether blocks or something. And if the child knocks the blocks over and the parent, yells at the child, the therapist would just gently remind the parent, hey, you know what? Maybe the child didn't mean it. Help the child. Look back to the child. Things like that. And in that moment, you're creating these little bonding moments where there was a break because the parent yelled, and then the parent comes back, helps the child. That child feels better. There's a repair. And so that's how they work through that. But bonding impacts that regulation piece. If a parent is dissociated, then it's hard for them to notice what's going on with the child, and the child's going to see that. That's the still face video. But it also happens with hyperaroused. When parents are aggressive and physically abusive to their own children, it breaks the bonding and attachment that exists between parent and child. And ESFT can help address that. Mentalization is another piece to it. Mentalization is the ability to perceive and interpret other people's thoughts and feelings. And so this is usually developed very early on. And so parents help children learn this, right? Peter Fonagy helped develop this idea. He believed that early attachment secures social interactions, which help develop the cognitive processes that allow for individuals to interact. So children learn from their parents how to interact with others. And that's the first place where they learn this process. And in parents where there's abuse, childhood abuse history, they may be in these triggered hyper or hypo-aroused phases where there's lots of high emotion, lack of ability to mentalize, which is the ability to see what's going on or think what's going on for the other person, to be able to predict that even. That's not there because of their trauma being triggered. And because of that, they have a failure to then relate and control their behaviors. In the example here that we see on the slide, it makes it very clear. When one family member, say the parent, is in this place where they have poor mentalization, high emotions, failure to empathize, that gets translated to the child. And the child doesn't learn proper understanding of empathy and caring for others and relating to others. They learn this very reactive, high emotion, controlling behavior that exists. And so parents who have this childhood sexual abuse may find themselves in a place where they have all this high emotion all the time. They're constantly triggered and they're unable to see the perspective of the child. In ESFT, we want to help change that by creating some opportunities to regulate oneself. And then with the attunement piece, to the ability to help the parent see what might be happening for the child, listening to the child. executive functioning pillar, I'm not going to say a lot about this, but the executive functioning pillar really is about executive parenting skills. So again, structure, um, routine, expectations. How well does the parent kind of run their home, right? And we know that when there is predictability and security, kids do better, right? And so executive functioning helps kids do better through clear expectation structures and roles. And this idea of cohesion um, also helps when there are clear boundaries, flexible boundaries that are supportive and warm. Um, that's Minuchin believed that. That's where the idea of boundaries comes from, these emotional boundaries of rigidity um, um, or enmeshment is this idea that in enmeshment boundaries aren't clear at all. They're messy. There's no boundaries. In rigidity, the boundaries are rigid and inflexible. Where with good boundaries, when parents have a good executive functioning as far as what people's roles are and expectations are, these boundaries allow for some of this support and warmth and empathy, which is what is needed. A lot of parents who have trauma cannot access these ability and skills because of their trauma. They don't do well at planning or strategizing or keeping things in order when they're triggered. And so because of that, their homes may be unstructured. They might struggle to communicate with their partner what they need or want from their child. And when that happens, you see some dysfunction that occurs in the family. But with ESFT, we want to address that by looking at how can we help the parent create some of these boundaries. First, we have to regulate them, which is going to be key when we talk about our case study. The final pillar in ESFT, and I do think it addresses trauma, is support for caregiving. We know over and over again, research has shown us that when people have a place to go where they feel like they belong, they feel safe and comforted, that's a place where they can heal from trauma. So places like church, a great opportunity we have as a church and as the Christian community to embrace those who are struggling, bringing them in and telling them, hey, this is a place where you can be safe and where you can share your concerns, where we can pray for them, where we can talk through them together, where you can bring your kids, to get a break even sometimes. And, you can come here to get recharged. So this idea of support for caregiving is really to create those moments. Church is one of them. YMCA might be others. There's just a bunch of different ones that will help the caregiver feel more supported by building this community around them. So let's look quickly at prolonged exposure. Prolonged exposure is derived from exposure therapy and emotional processing therapy. I know a lot of people who do prolonged exposure don't like to use that term because of the negative connotations that sometimes people have about it. But the goal really is to emotionally process the traumatic experience to reduce then the PTSD symptoms. And FOA believes that PTSD leads to avoidance. And so these avoiding behaviors that people are doing are actually trapping the trauma, not allowing the trauma to be processed and to heal. And so that's where the exposure comes in. So PE is going to provide some psychoeducation about trauma in the beginning. They're going to look at in vivo exposure to the traumatic memory, where the person will talk through that traumatic memory in session with the therapist. And then prolonged imaginal exposure, again, is where they continue to expose themselves to that traumatic memory and practice skills of hearing the memory, recognizing that they're safe, and not responding to it then. PE outcomes, there's good outcomes for PE. It's been shown to reduce PTSD symptoms. It's effective as rape survivors, those who have been sexually assaulted, military trauma, and child sexual abuse, which is what we are thinking about using when we integrate it with the ESFT. And also helps to reduce symptoms of anxiety, depression. And so these outcomes are promising outcomes that can be used to integrate the effectiveness of ESFT with PE. Spending a little less time on these two because people may be more familiar with them, but somatic therapies are based on the belief that trauma is embodied in our cognitions and our senses. So again, the mind-body connection, right? How does the brain and body respond to trauma? How do we think about our traumas based on our experiences of those senses? And so somatic therapies, instead of using kind of a top-down approach, which is executive functioning at the top of our brain, to back into our system, to use a bottom-up approach, which is really looking at those experiences that are occurring in our body and recognizing them and how they might impact then how we think and how we react. Two examples of those are sensory motor and somatic experience. Both of those are two theories that have some evidence behind them. I wouldn't say that they're evidence-based practices, but they are evidence-informed for sure. And somatic therapy often uses mindfulness to focus on body sensations and cognition. So again, the idea of focusing on what's happening on the body and then how we think about that focuses on regulation strategies that address the autonomic nervous system. So when we think about how do we settle down the autonomic nervous system with parents who have child sexual abuse in that emotional regulation stage with ESFT, one of the ways to do that is by using somatic therapy. It also provides clients the opportunity to become aware of their hyper and hypo-aroused states without judgment. And that last piece is important, without judgment. Oftentimes people recognize that they are either hyper-aroused, yelling, screaming, whatever. Hypo-aroused, often people may not know, but people are telling them, hey, you look down and out, you're disconnected, you're just disengaged. But oftentimes that comes with judgment, right? I'm a bad parent because I'm hyper aroused. I'm yelling, screaming at my kids all the time, or I'm a bad parent because I, struggle to get off the couch some days. But somatic therapies are really going to ask the client to look at those arousal states without judgment. Sensory motor psychotherapy has some limited studies, but it does show effectiveness in group settings. And somatic experiences is similar. It has been shown to have promise to address PTSD symptoms. In the integration of the three, we're going to be talking mostly about pieces of each of those, not necessarily specific model of somatic experiencing or sensory motor psychotherapy, but instead, what are some of the interventions or tools that are used in those two therapies that could be integrated into our ESFT model? So when we think about integrating the models, we want to think about, are they going to be a good fit or not, right? And so Harwood and Gross et al. Found that military veterans really showed that there's a lot of similarities between sensory motor psychotherapy and somatic experiencing, which means that, these two approaches play off of one another, which is good. Brief family intervention has also been used in the military personnel to enhance PE treatment. So brief family interventions is really just 2 sessions with family members that goes over like psychoeducation and some other pieces that has been shown to enhance the treatment of PE in those in the military. And ESFT itself allows for integration of other models of treatment that support the 4 pillars. For example, it's very common for therapists to use DBT, dialectical behavioral therapy, strategies for adolescents to support emotional regulations. So to integrate PE and somatic therapy into ESFT is really not a stretch. These are models that could have the potential to work together. And here's some other reasons why. All 3 of the models focus on the regulation of emotions triggered by trauma. In ESFT, it's not always trauma, but there's a lot of emotional dysregulation that occurs based on trauma in ESFT as well. And the goal was to address that. And each component has a component each model has a component of utilizing in vivo as well to address the traumatic distress, meaning um, they're going to talk about what's happening in the moment. In ESFT, when there's dysregulation, the goal is to help the parent and child learn to regulate together, to create an opportunity for there to be safety. And so that's addressed right in the moment, right? Same thing with PE and somatic therapy is that to address them, we address them when they're happening, right? Um, so I think the best way to think about how would this integration look is to do a case study. And so I proposed a case study. There's not a lot of information on the slide. It's hard to put a bunch of information in there, but I think I have the key pieces to just get us started on what potentially could the model look like if we were to integrate PE, ST, and ESFT together. And so Johnny's a 12-year-old male with risky behaviors, suicidal behaviors. He's been in and out of psychiatric hospitalizations. His current diagnosis is ADHD. Johnny lives with his mother Judy, and his little sister Annie. So it's just the three of them. Mom works full time as a nurse, so she works long hours and struggles often with money. Previously, she'd been married to Johnny's father, but left him due to domestic violence. Judy also has a history of child sexual abuse that was perpetrated by her father. And when she is home, she spends a lot of her time alone in her room and sometimes passes out due to drinking. Johnny then does a lot of the caring for the child. So Johnny watches his little sister quite a bit. And in the past, he's actually protected his mother from his dad, in fact. Currently, dad is out of the picture. He's incarcerated and not part of our treatment. So if this was our case, and we wanted to apply ESFT with the integration of PE and ST, here's how I think we could do it. First, the goals of treatment. One, we want to reduce the suicidal behaviors of Johnny, right? That's what's bringing him to the treatment. It's what's causing a lot of the distress. We want to increase Johnny's mood. He's got depressed mood. We want to reduce trauma triggers that are displayed by mom Judy. And how does mom display those? We'll talk about those. And then we want to increase family functioning, meaning we want to increase Judy's presence with her children, right? She spends a lot of time in her room by herself. She avoids by using alcohol as well. She may even be avoiding by working long hours. Obviously there's a financial component, but for some reason she's avoiding her presence with her children, and we need to reestablish that. So how would we do that? Well, first we would do assessments. We would do, and this is in line with ESFT expectations. We would do assessments. We'd do individual sessions with Johnny. We'd do some caregiver sessions with Judy. And then we would want to do family sessions with the whole family. In our assessments, we're going to use genograms, timelines, and eco maps alongside of some other tools like the CAPS or the CPSS. So these are childhood trauma screeners, lifetime trauma screeners. We could use the ACE scores as well. And when we do so, we're going to identify some things, right? So in the genogram, we identify that there's conflict between the child and the parent. We identify that a lot of that conflict is avoidance. So there's a lot of distance between family members. We recognize that there's a family history of abuse, that parent was also abused. So the child, Johnny, sees his mom being abused. Mom was abused as a child. So there's this generational history. So when we look at the genogram, we can see, hey, this family needs some help when it comes to addressing their trauma. In the timeline, we were told by mom about her sexual abuse, that it was perpetrated by her father when she was 5, 6, 7, and that since then she's been herself in and out of treatment for therapy. As a teenager, had her own addiction, and now into where she is now with the domestic violence with her husband, ex-husband. The ego map we use to formulate who is in the system that could be supportive. So we're going to be looking at who else is in Judy's life to help her. Is there any other family members? Is there a church? Is there a local community center? What might be available? Um, and so once we do the assessments, we then come up with what we're going to do in our treatment. And I think with this case, what we're saying is there's a child who needs some help with his own emotional regulation. Mom needs help with emotional regulation, right? She seems depressed. She seems to avoid. Maybe she's trauma triggered by her son with his depression and his suicide. And that trigger is, she gets triggered, hypo aroused, right? She goes away, she hides, she doesn't explode, right? Um, and then we also recognize that mom doesn't spend a lot of time with the kids. So is she again avoiding that, right? So for our individual sessions, we've decided we're going to look at doing some somatic techniques to identify bodily sensations and cognitions when Johnny is triggered. So we're first going to just do some body awareness, maybe a body scan with Johnny to go through what's going on for him when he's triggered, right? What is triggering some of those suicidal ideations and behaviors? How does, the trauma that he witnessed impact what's going on for him, and where does he see or feel it in the body? And we're going to do so non-judgment, right? So we're going to do a body scan, just recognizing and noticing where some of those things are. And then we're going to practice strategies to regulate him when he's distressed. So we might use the 5 things exercises or the 5 senses exercise, where you use all 5 senses to look around the room, and you do 5 things that you see, 4 things that you hear, 3 things that you can touch, 2 things that you can smell, and then 1 thing you can't taste. But if you were to taste it, maybe there's something in the room that looks delicious. All of that can be done in a moment when he is triggered, right? Those are grounding techniques. They're somatic experiences where we're using our body sensations and our senses to regulate ourselves. And so we would do that with Johnny in our individual sessions. We'd work through a lot of that with him, preparing him for being in session with mom as well. For the caregiver sessions, we've decided that we're going to conduct PE with the family for the mom. And so, because she has the child sexual abuse history, it's a very specific trauma, and it's something that continues to give her distress. She shared that with us. She talks about it with how one of the reasons why she avoids. And so we're going to do PE with her in our caregiver sessions. And so we're going to do some psychoeducation about CS, child sexual abuse at the beginning. We're going to identify some of the less intense emotions and begin to talk about those. We're going to utilize homework to begin exposure treatment. And we're going to use in vivo practice to follow our engagement with more intense triggers. And, we're going to use Rothbaum et al. 2019, and that is a workbook that goes through the prolonged exposure process. And we're going to do that with mom with the intention of helping to reduce her symptomology of the trauma that she has. In family sessions, we're going to use enactments to engage conversations about these things, suicide and trauma. So again, in ESFT, we don't skirt around the elephant in the room. We talk about the elephant in the room. The elephant in the room is suicide and trauma, right? And so we're going to engage in these conversations. When we do, obviously, you're going to see some escalation, right? People are going to be triggered. Hopefully, the work that mom's doing with PE and the work that the son is doing with somatic strategies is going to help. But one of the activities that we can do is look at this windows of tolerance worksheet. I'm going to flip to the next slide just so we can see it. But this is a visual from the NICADM website. They provide those free. You can go and pull this off. But this can also be used as a worksheet where you can see that hyperarousal is at the top, and hyperarousal, again, this is where we are out of control. We're angry, yelling, screaming, wanting to fight. And then there's hypoarousal at the bottom, and that's where you're zoned out, space, numb, kind of not feeling and avoiding. And in between those two is the window of tolerance. And that window of tolerance, this is the space where you can tolerate the feelings you have. People with childhood sexual trauma that's not been treated might have a very small window. Children who are being raised by parents with childhood trauma might have very small windows, right? Um, our friend Johnny also has ADHD, so his window of control might be less, even more, right? So we put all that together, and we got a family, a kid with maybe a really small window. The goal, the goal with this worksheet is to identify hyperaroused states so each person in the room would get an opportunity to do so. So we'd ask each person, hey, when you're hyper aroused, what does that look like? How often does it happen? When do you think that happens? And then we go back to the hyper arousal. When is it that you feel most disconnected, shut down? What's it like in your body? Things like that, right? And then when we talk about this window, how can we expand this window? And the way that we expand this window is when we recognize we're in one of these states, we do an activity or an intervention that allows us to drop back down into that window of tolerance or pull ourselves back up into. And so for hyper aroused, a lot of times you're doing things that are calming. You might be doing box breathing. You might be doing some meditation and mindfulness. Um, you might want to use prayer in that place where, hey, I'm really out of control. I just need to take 5 minutes to say some prayers, separate myself, feel a little calmer. Um, you could do other body activities as well for hyper arousal. You could walk slowly, do some mindfulness walking. There's a couple different strategies. Hypo arousal, you are trying to activate the body. And this is where you might pull in polyvagal theory, where you try to activate the voice cords in your voice. So humming is one of the activities that they do in polyvagal theory, or listening to bilateral stimulation music, put on your headphones and listen to that music to help you kind of get back into your window of tolerance, and in polyvagal theory, back into the ventral vagal system and out of the dorsal vagal system. And you're going to do this with the family. You're going to do this activity. They're going to do it together. And then every session when you're there, when you begin to see someone hit that window or leave the window, whether it's up or down, you're going to stop, reference this potentially. You're going to look at how we can change the current situation so that we are regulated. That's just one activity. There's others that you can do in family sessions to help people learn how to regulate and co-regulate with one another. This one's a good one because it's visual, something they can do together, and it's something that is tangible for parents. I would be remiss if I didn't talk about some of the challenges to the integration. There are challenges whenever you're going to integrate evidence-based practices, evidence-informed practices with other practices. One, you could lose focus and intentionality. You wouldn't want PE to overtake what you were doing in ESFT, right? If the family's coming into the ESFT program for the suicide, you wouldn't want PE to become all that it's about, right? You don't want to lose focus with the child's needs. We are going to be addressing, we're just going to address it through the parent. And then there's drift from models. When we are implementing any evidence-based or evidence-informed model, there can be drift. One of the great things about ESFT is you have a lot of supervision. There's weekly supervision where you can talk about that and you can make sure that you're not drifting, right? Same thing with PE. There's a manual. You can follow the manual, make sure you're sticking to it, right? Dropout rates. So, dropout rates in these high stress families may be higher than in, say, an outpatient setting. And so, you might lose someone. If you lose someone in the midst of PE, then they don't get the whole treatment. Or if you lose them for ESFT because of something, they're in the ESFT program and then they have to leave for one or other reason, the parent doesn't get that treatment. So That can be a challenge. And then training, integrating ESFT with PE and somatic therapies means, ESFT already has a very stringent training regimen, right? It's a 3-year program. There's about 80 hours a year that you have to do in order to get trained in ESFT. To add then another model like PE could create training overload, right? Um, it has been done. Personally, I've been trained in MST CANS, and MST CANS implements PE when a parent has an identified trauma that is impacting parenting. And so I know that it can be done in a family therapy model, but it does add that extra piece of training. So I think that's kind of the challenges that I see with integration. Not until it's done would we know what specifically they would be. I do want to leave with this just because, I want people to understand that the reason I'm so passionate about family therapy, ESFT, and then integrating some of these other models is because I really do believe that relationships are the key to healing. Um, Judith Herman or Edith Herman, sorry, I think her name's Edith. I have the book right here. No, it's Judith. Judith Herman, in 1992, she wrote Trauma and Recovery. It's kind of uh, a big book, right? It's like body keeps the score. And in that book, she wrote that recovery can only take place in the context of relationships. And that in particular is talking about trauma. And I believe that. I believe that trauma treatment without family component may be less effective, especially when you're dealing with adolescents or parents who have childhood trauma and are parenting. And so I'd encourage people to think about how can we incorporate ESFT or other family therapy models with these more trauma specific models so that we can help people truly recover and feel better. Um, that is my presentation on the combination of those those three models together to address child sexual trauma and child sexual abuse. I hope that you learned something from it. I hope you took at least one thing away from it. And if you need more information, there will be a reference page presented as well that you can go and you can look up some of these books and resources in order to find out more about ESFT, you can find out more about prolonged exposure or somatic therapies as well. Thank you.